because we haven't talked about this, and we actually don't talk about this enough. And thus it's become a subtly neglected topic, and that is women and heart disease. We're going to emphasize initially the aspects of women's health and why women are missed with respect to the #1 killer amongst women, men as well, but women as well. We think of women's as not developing heart disease, but in reality it is far and away more prevalent than breast cancer or gynecologic tumors or any of the other causes of illness that we get. But you know, women are protected until they reach menopause by estrogen, and therefore when they do hit menopause, their onset of atherosclerosis or heart disease is about 10 to 15 years behind their male counterparts. So we've all kind of grown up thinking that women don't get heart disease. And I will also tell you from my experience, both professionally and personally, women are a heck of a lot tougher than us guys. And they don't complain. They just don't complain. They've learned to bear discomfort and push on, much more so than men in general. And it also turns out, and we'll talk a little bit about this, that the symptoms that they get are commonly different than those of men. So not only, again, is this a societal factor, and that is we all accept that women are just kind of stronger than men, and when they complain, and women believe it as well, that they'll get through it, and most of the time they do. And women are tougher. And it also turns out that women, being smaller human beings, have smaller blood vessels. So when problems do arise, problems arise more quickly in women. And unfortunately, because they're tougher, they commonly present a little bit later. You know, we have an interventional angioplasty program here. That is, patients with heart attack in the community are rushed like a Chinese fire drill to the cardiac cath lab because we believe, and it's fact, a Nobel Prize was awarded for this. We know that every minute gone by is loss of heart muscle, and the ultimate strength of your heart as you leave the hospital after a heart attack dictates your long-term prognosis. So we're going to talk a bit about that, women, and then heart disease in general. So this morning, part of the reason I arrived a little bit late, there was a 60-year-old woman who recently visited me at the office, and she had seen another doctor who, when she complained of shortness of breath, told her to stop smoking. She doesn't smoke much, but she does smoke. But she was having shoulder pain, and she had seen an orthopedist, and the orthopedist felt that this was probably some cervical or musculoskeletal discomfort. But in examining her, when I saw her at the office, I noticed that the pulses in her feet were poor, and she probably had peripheral arterial disease. And her ability to walk far was somewhat limited because she had blockages of the vessels in her legs. So we said, well, let's just make sure, given that you're a smoker and you're having some atypical symptoms, let's do a heart catheterization. Our stress test was done, revealing the bottom of her heart not getting enough blood, but she's a large woman, and sometimes the diaphragm sits up. But given her risk profile in this 60-year-old woman, and knowing that you all wanted to see this film today, we did a heart catheterization on her a few minutes ago. So this is hot off the press. She's still here in the hospital. But if you can roll that, can you play that in real time?
Yeah.
So this is the artery. So let's give a little anatomy lesson. I want you to think of a football. All right, the laces on the football across the front of the ball. The laces correspond to the location of the anterior or front vessel on the heart, the anterior descending. The laces run down the front. The quarterback holds the football around the circumference, around the side, and we refer to that blood vessel as the circumflex artery. And then there's a third artery that runs along on the back side of the heart. So there are 1, 2, 3 arteries on the heart. Commonly, people experiencing symptoms or coronary insufficiency related to the artery on the back of the heart may complain of stomach, heartburn, indigestion, gas, bloating, All right, and that's because the right coronary artery, the artery on the back of the heart, is fed by the same nerve that goes to the stomach. So people may be having a heart attack and they say it's the damn sausage and peppers I had this morning. Okay, but their symptoms may be different, just like women's are commonly different. Okay, so there are three arteries. That on the front, the anterior descending, we call it the widowmaker. That on the side, the circumflex, and that on the back of the heart. And again, the back of the heart also controls the heart rate and the heart rhythm. Sometimes when that blood vessel closes, the heart rate goes very, very low, and people may faint. And the fainting is due to, or secondary to, the heart attack in occurrence. All right? I will remind you, just as people with diabetes have an altered pain sensation as well. So they have neuropathy. Some of you may have diabetes and you know that the sensation in your feet is not the way it used to be. Well, that same alteration in pain sensation accounts for why people have an alteration in the sensation of angina or chest pain discomfort that we typically get. All right? And they may go, 40% of women and about 30% of men never feel the pain of a heart attack. They may feel shortness of breath. They may feel profound fatigue. They may feel sweating. Okay.
So when we hit on the play button, it's not going forward.
Why?
It won't play.
Oh, I can help you with that. I've seen this before. No, stay, because you're going to do them. So what you need to do is click on the box.
In this box?
Mm-hmm.
Okay.
Elisa Sheridan, 5726. Elisa Sheridan, 5726.
Mm-hmm. You want to call Alice?
Okay.
Anyway, you can call Alice if you like, but it's not that essential. There are other pictures. So what happens, I want you to think of a wine bottle. And the wine bottle, or the channel of the wine bottle, is narrowed by the neck. And that narrowing at the neck has to do with plaque accumulation or cholesterol accumulation in the wall. Our blood vessels have rings, like 3 rings of an onion skin: an outer ring, a middle ring, and a center ring. And plaque accumulates between the inner ring and the middle ring. Okay? As it does, blood vessels, and we're going to talk more about this, I'll show you some interesting pictures. Blood vessels, because of the tendency to maintain blood flow, our blood vessels, which are circular, elongate to accommodate for the plaque that's accumulating in the blood vessel wall, keeping the channel of the blood vessel the same as it was in youth. Eventually, after about 40% of the elongated blood vessel's diameter has now been narrowed with cholesterol plaque, it begins to impinge upon the channel. All right? Here, in the proximal portion, in the upstream portion of this blood vessel, which runs down, the laces on the football are here, is a plaque or a cholesterol deposit. So we live a long time with a narrowed neck in the wine bottle, and nothing much happens. The largest blood vessel, the largest organ in our bodies is skin. We have skin on the outside of our bodies called epithelium. We have blood vessels lined with skin called endothelium. And cumulatively, surface area-wise, the endothelium, the epithelium, far and away make up for more volume of cells. So we get a cap. If you have a cholesterol deposit in the blood vessel wall or at the neck of the bottle of wine, okay, that inner lining is lined by a callus, where the endothelium has grown larger and thicker to protect the cholesterol from the bloodstream. Because when you mix the two, cholesterol and blood, it promptly causes a clot. Okay? Something happens at a given point in time when the callus or the endothelial cap fractures or breaks on the inside of the blood vessel, lining the inside of the wine bottle. And at that point, that's a bad day. That's the point at which a clot forms. And that clot forms like a cork in the wine bottle, and it closes off flow. So in the old days, you may remember we gave clot busters. You'd hurry to the hospital. You might feel chest pain. If you're a woman, you might feel shoulder pain, back pain, sweating, or just profound fatigue. But you get to the hospital, hopefully, and we gave you a clot buster. Today, we get into the blood vessel, with an angiogram like this. The catheter tube is inserted from the blood vessel in your arm or the leg, and we're able to introduce this hollow tube, and through it we pass a little wire that commonly pushes the clot downstream, and then we put in a balloon, stretch it open, and place a stent. Interestingly, you know, if you had a piece of metal or a splinter in your body and you left it there, eventually it would become encased with scar tissue. So our old stents left in a blood vessel would scar. And the stuff that re-narrowed blood vessels after stents were placed was scar tissue. We used to tell people, we used to admonish people when they went home from having a bare metal stent without the drug on it, we would tell people, if you smoke, or if you don't get a handle on your cholesterol, well, it's going to come back. It's going to re-narrow. We then developed a device that we used to open blood vessels, and it would shave off the inner reaccumulated stuff, whatever that was, inside the blood vessel. And we learned that there's no cholesterol here. This is scar tissue. And the cholesterol was elsewhere in the blood vessels, but the scar tissue was what was re-narrowing these things. Somewhere around 2004, a stent was developed using a drug that was found on a Pacific island, actually, in clay there. That was an antimitotic, almost like chemotherapy. And they would coat the stents with it, and the stent went into the body inertly. That is, it wasn't even recognized by the body as being there. And with that, the re-narrowing rates of our stents went from about 25%, 1 out of 4 stents that were placed, to about 5%. So today we use those types of drug-eluting or drug-coated stents, and they're very effective to open blood vessels. We're kind of getting ahead of ourselves. Anyway, so you might see, lights down? Can we lower the lights? Okay, so this is a narrowing here, and it's rather eccentric, and I told you that this person, how many of you have heard of the A1C? A1C is a blood sugar measurement that enables us to get a handle on how tightly your blood sugar has been controlled. The hemoglobin is a molecule in the blood. It's just a blood cell, part of the blood cell. And we look to see how much sugar is stuck to it. But sugar, when it's poorly controlled in our circulation, sticks to other proteins as well. Namely, and importantly, it sticks to blood vessel walls. So in people with diabetes that's poorly controlled, the blood vessels become cross-linked with crystalline sugar, just like the A1C. And it's proportional to the degree of lack of control of your blood sugar. And the more stiff your blood vessels are, the less the blood vessels can elongate. And this is thought to be one of the reasons that diabetics get coronary disease faster, because their blood vessels are stiffer, they can't elongate quite as readily. Anyway, why don't we skip that and go ahead to the program that I was referring to earlier. Why don't you go back to the, yeah, okay? So we're going to get started, but you see the narrowing here, and if, Johnny, can you flip it to the right coronary artery? So the right coronary artery, so this is the catheter, these are the arteries that sit on the outside of this person's heart, and her symptoms, as we said, were somewhat atypical, but we indeed found that the nuclear stress test done on her did disclose that she had a narrowing feeding the back vessel of her heart, and the bottom surface of the heart was not getting blood during stressful periods. Okay, either way, why don't we go ahead to the next, to the Go Red for Women portion of our talk.
We're good? Okay.
I just fell asleep or something.
So women in general, as I said, there's a societal sense that women don't get heart disease. Women tend to be tougher. Women tend to have smaller arteries, and they get atypical symptoms. But the incidence of coronary disease in women is actually, after menopause, the same as that of men. Prior to menopause, and this may have to do with hormonal factors, prior to menopause, women have a higher incidence of coronary disease than any other life-threatening condition. What are we doing, guys?
It lost power.
Oh, okay. Anyway, show and tell. So this, I'm going to pass it around. is a very interesting device. It's made of a unique new type of metal, which is an alloy of nickel and titanium. You can take it and deform it in any way, shape, and form, and it returns to its original configuration. It's been taken and molded into the shape that you see here now, and a cow pericardium, that is the sac around the cow's heart, has been taken and fashioned into a new heart valve that is sewn by hand inside this transcutaneous aortic valve replacement. It's flexible because it's able to be crimped and pinched down on a catheter tube like the one you saw here, and we pass it from the leg up into the narrowed valve of the heart. Imagine the added work if your heart, which is a hollow chamber and a hollow cavity, had to pump blood rather than through a $50 sized hole, through a hole the size of half a dime. There'll be a lot more work to squeeze the blood out and around the body. Additionally, because of that extra work, the amount of oxygen necessary becomes much, much greater for the heart muscle to do its work. And if you have moderate or severe narrowings, it becomes even more problematic for you. So today, we take from a puncture in the leg, we take a balloon, thread it through the narrowed valve, and with that balloon, we crack the calcium in the valve, and then we put in this device, which has a valve inside of it. And it excludes the calcium and the old leaflets that we've had in place since our births. Obviously, the edges of the calcium are irregular and ragged, and the blood may well jet back through the hole around the valve. So they've fashioned this with a foam-like substance like that which you buy at Home Depot and spray into the crevices of your home. And it swells when it gets wet with blood. So it swells and makes an appropriate, adequate seal. This is called a core valve, or a TAVR, a transcutaneous aortic valve replacement, and you're in the hospital for about a day and a half afterwards, and it obviates the need to do open heart surgery. Okay? While they're working, I'll pass this around. Please return this. It's $50,000. No, it's a shame. It really is a shame. That one, yeah. I'm going to tell you another interesting story about technology and innovation. Some of you may have pacemakers, all right? A pacemaker is a hockey puck-sized battery under the skin connected to a wire that's threaded into the tip of the heart. Some Silicon Valley engineers from Palo Alto had lost their jobs. They're typically a lot younger than all of us, young kids, and they had young families, and they didn't want to move. So they went looking for work in the San Francisco Bay Area, hoping they could apply their technological skills to some other field since they had lost their job in the computer industry. Three of them went to, read only, three of them went to Santa Rosa, which is north of San Francisco, up in the wine country. And they visited the pacemaker companies and sat with the pacemaker people and said, well, what do you got here? You know, we're electronic engineers, we're computer engineers, we can do anything. What do you have? Well, we have this battery, and the battery recognizes when the heart beats, and when the heart doesn't beat, the battery fires a spark and stimulates the heart. They said, well, why is it that size? They said, well, we have a lithium battery in there, and we have the technology there to assess every single beat of the heart. In fact, the doctor can come by afterwards and ask the pacemaker whether it's seen any irregular beats or whether it's had any atrial fibrillation. There's a lot of information in that battery. And they said, well, okay, well, why is there a wire connected to it to go into the heart? Don't you guys have cell phones? And they said, well, yeah, we have cell phones, but they said, can we just work on we're going to get back to you. So these three electronic engineers from the Silicon Valley came back to them and said, you guys are in the 18th century. We've developed a prototype that has all the technology of your hockey puck battery, and you don't need a wire, and we've put all that same pacing information in a Tylenol-sized capsule. And we're going to connect it to a catheter tube that you'll put in from the groin. And there's no wire or anything, because after you put the wire in, if you're in Indonesia, God knows, or Bhutan or something, the likelihood is the guy's going to go back home and it's going to get infected. There's no medical follow-up or care. So the possibility of infections are great. And who's going to follow this thing? So they made a Tylenol-sized pacemaker. All right, it's a Tylenol capsule that sits in the tip of the heart. No wires. They release it, and you go home with a little Band-Aid on your leg, which heals up a week later. And the future of pacemakers will be tiny little pill-sized devices that insert into the heart, and then using a cell phone-like device, you tell device A to talk to device B, and this is the delay and the interval. And by the way, if you have a heart rhythm disturbance, activate it, and it took, but so there's an industry, a billion-dollar industry, that's been doing the same thing for decades and decades and decades. And it took somebody to come in thinking out of the box and revolutionize this overnight. And they've been asleep at the wheel, thinking about the changes in technology. And it's not just about technology, but it's going to ultimately translate into phenomenal benefits in health. Because one of the most dreaded things we see are infected pacemakers. If a pacemaker gets infected, you naturally assume that that infection is in the heart, what we call endocarditis, which is a dreaded disease state. So these are fantastic new devices, and I think we've bought enough time that we can go on to our talk. Okay, so we're going to go red and fight heart disease in women. Go ahead. What is heart disease? We've talked a little bit about that. Why is it important? Because it's the #1 killer. What have we learned? What is a heart attack? A heart attack is when that wine bottle fractures and a clot forms and it plugs off the blood flow, so no blood can get to the heart tissue downstream, and that causes death of heart tissue, and that is by definition a heart attack. Many people think that if you've collapsed at the mall, you had a heart attack. Not necessarily. You might have had an arrhythmia. Why are we at risk? We're all at risk. There's actually something now which is really cool. I want you to follow this concept with me. Accept the fact that heart disease is the #1 killer in the world. It's the #1 disease that people die of, okay? But most people in the world won't die of heart disease, all right? They will die of the aggregate of all the other things that could do us in. Wouldn't it be interesting, as a society, if we could look across 100 people and say, you 18 people are going to get heart disease. We need to treat your high cholesterols and put you on aspirin and all that other stuff. And you 72 people aren't going to get heart disease, so watch your cholesterol and go have a good day. And that would be really interesting and useful and efficient from a pharmacology point of view too, because think how many people take statins because their cholesterol was high, but they were never going to get heart disease. So now we actually have, like Dr. Spock, like Star Trek. Remember Bones, the doctor, Dr. McCoy used to say, oh, you have a torn rotator cuff, and with his wand he'd say, oh, and you have a liver cyst, and you have a kidney stone, and now there's a scan. So you lay on a table, and the machine, you don't even have an IV in. It's a very low dose radiation, and it runs you in, runs you out, and an hour later we get a score of how much cholesterol and calcium you have in the arteries of your heart. I didn't point this out before, but when we were looking at the catheterization of that woman, which in addition to the blockages, which I hope you appreciated, we could show you later if you're interested, there was calcium or graying in the blood vessel wall. That's calcium. So where cholesterol lays down, your body senses the abnormality in the blood vessel wall. It's a foreign substance. And your body creates an inflammatory reaction which lays down calcium. Just like when your shoulder gets stiff. When it's inflamed, you get bursitis or arthritis, because inflammation leads to the development of calcium. And it turns out, and we're going to see this in one of the slides, why don't we go forward, that inflammation is probably the reason that the plaque fractures, that the callus on your plaque fractures. Inflammation is why cholesterol lays down in different parts of your body. These are just images of the heart. Put the lights in the front down. So here's a heart. I want to point out to you, and I just want you to think conceptually because you're all students of heart disease, all right, that we really have two hearts, okay? We have the right heart, which is working simultaneously right alongside on every beat with the left heart. And the right heart pumps blood into the lungs, unoxygenated blood into your lungs. And then oxygenated blood runs simultaneously. This is a process that's happening every beat, but two hearts. The right heart receives venous blood from the veins of your body without oxygen, the blue blood, and it then turns red when it picks up oxygen in your lung and pumps out around the body and provides the metabolic circulatory needs of our body. So there are really two hearts. And when we have lung problems, pneumonia, asthma, smokers, sleep apnea, which is incredibly prevalent, but we tend to be a trim crowd, I must say. I commend you all. But in society, this sleep apnea phenomena, as America fattens, is becoming more and more of a problem for us. So all those diseases, emphysema, sleep apnea, pneumonia, asthma, smoking, affect the right heart. And coronary artery disease, that we typically refer to as heart disease, is really affecting the left heart because that's where the meat of the matter is. That's where the heart muscle is. When we pump blood into the lungs, we pump 30 millimeters of pressure into the lungs. And when that's simultaneously pumping left ventricle, much thicker left ventricle here, the wall thickness, is pumping out around the body, it's pumping at 120 millimeters of mercury. Here's an old pacemaker, not like the one I was just referring to, but it goes into the heart here. Wouldn't it be cool if we could do away with all of that and just leave a little pill-sized capsule sitting at the tip of the heart like that? Go to the next picture. So these are our risk factors. What's the most important thing you can do to prevent heart disease? Pick the right parents. So it's interesting, though, and you may talk to your doctors about this. All right, there's an interesting community in Massachusetts called Framingham, and there's a Framingham risk score where we ask you, are you diabetic? Have you smoked? How old are you? What's your cholesterol? So on and so forth. Interestingly, in this very sophisticated algorithm or equation that we use, all right, is the absence of family history. Because family history, it turns out, means a lot of different things. It can mean a high LDL cholesterol. It could mean a low HDL cholesterol. Go forward. All right. Obviously, you all know about hypertension. Hypertension's important. It beats up our blood vessels. The higher you bang the blood vessel, with the higher the pressure, the more damage. This is an interesting phenomena. So it turns out that at 45 years of age, human disease, by and large, at 45 years of age, human disease begins. So our blood vessels have collagen, which is like shoe leather, the tough stuff that keeps the blood in the vessel, and elastin, like the stuff in your underpants. All right, so when a blood vessel beats, or when the heart beats into a blood vessel, it expands and then it contracts down again. Systole and diastole, 140, 70, 140, 70. At around 45 degrees, 45 years of age, in humans, different in different animals, depending upon your risk factors, or are you a smoker, do you have diabetes, so on and so forth. But around 45 degrees, the elastin fibers start to snap. All right, it's been a long time. 45 years is a long time. So there's a lot of wear and tear, and the fibers begin to snap. So the vessels are no longer able to buffer the waveform of pressure that's going through your blood vessels. All right. It turns out that each time a blood vessel branches, or we call bifurcates, that waveform, you know, you've seen in cardiac rehab or in your travels, you've seen the blood pressure spikes and comes down, and spikes and comes down. But every time a blood vessel branches, the waveform becomes a little bit less spiky, such that after it branches and branches and branches about 100,000 times before it gets to the end organ, that is the brain, the heart, the kidney, so on and so forth. Eventually, the blood flow, because there's been so much branching and the blood vessel is flexible, the blood flow to your brain is like this. It's consistent like that. But as our blood vessels stiffen, and our risk factors promote the acceleration of the stiffening, the amount of buffering that takes place or flattening of that waveform diminishes. So that conceivably, okay, if you have really stiff blood vessels, the brain is seeing this, or 140 over 90. And you can imagine what that does after 70 years. So we're fashioned to buffer the blood pressure waveform. That's why blood pressure is so important. And risk factor modification seems to be so important, because we can diminish the amount of snapping of those elastin fibers. So look how prevalent this is. Cardiovascular disease causes about 460,000 deaths a year. All right, and 1 in almost 3 women die of cardiovascular disease. All right, 64% of women who die of heart disease didn't know they had a problem. All right, previously, and cardiovascular disease is preventable, especially if we can define who's going to get it. Go forward. So here we are. We're going to go through quickly through this infomercial, because there's a national campaign trying to raise awareness of the fact that women, too, suffer the same disease as men, and they need to be a little bit more perceptive because some of their symptoms are different in presentation than those of their male counterparts. So lifestyle, exercise, okay, and it's important to recognize what your individualized risk factors are, okay? Chest discomfort, yeah, that's the most common presentation amongst women, but there are many, many others. Okay, women often suffer with discomfort anywhere in their upper body. I saw a lady recently who completely ignored the fact that her shoulder bothered her each time she would do the laundry. She stopped doing the laundry. So, but she had a heart attack. She was having a heart attack. And the reason she had chest pain, and that's another thing. We all fall into that. Do you have chest pain? No, I don't have chest pain, but I have shoulder pain every time I do the laundry. Or every time I take in the bundles from the car. I get this funny sensation up the back of my neck and I break into a cold sweat. Well, that's unusual, isn't it? What does that mean? It's seemingly something related to exertion and activity. And the way doctors think is that when you put the pedal to the metal, whatever the symptom's going to get in your car, that's when your car is going to stall. That's when you need more flow through your fuel line. When the car is idling, it needs less fuel. So if these symptoms are developing at rest or awakening you in the middle of the night, okay, I don't want to give you a false sense of security, but it's less likely. All right, it's more likely when you're exerting yourself and having, to increase your pulse rate and your blood pressure is climbing, then that's when you're going to have angina. Now, again, in women, it may be something other than the classic ton of bricks on your chest. It may be a funny sensation in the neck or the shoulder or the back or an unusual thing, but it's intermittent in nature. Okay. The shortness of breath has to do with the fact that the heart's a pump and it's emptying the lungs. And when the heart stops moving because it's not getting enough blood backs up in your lungs and you sense this as shortness of breath. And when the symptoms go away, the heart usually starts beating nicely again. This is something that's really quite relevant, and we get this all the time in the office. People come to see me in the office and they say, I had chest pain last Tuesday. Well, how long did it last? It lasted for about 15 minutes while I was climbing the stairs. How's my electrocardiogram? I can basically tell you that if you had 15 minutes of chest pain, you didn't have a massive heart attack, and the probability is your electrocardiogram is going to be normal. Okay? Because the EKG only changes when there's been death of heart tissue. All right? And long prior to, you saw the 90% narrowings when we go forward. You saw the 90% narrowings of the blood vessel in that woman, but at rest, she has normal blood flow. Okay? Keep going. Cholesterol, blood pressure, inactivity. What's your cholesterol? What is a normal cholesterol? So for the average Joe, all right, there's no right answer to that. It depends who you are and what your risk profile is. Okay, and if you already have plaque in your arteries, then your cholesterol, no matter what it was before it got treated, needs to get treated further, because there are people who have a cholesterol of 180 who have a heart attack. So all we do know is that, and 180 is considered less than 200. So one would say, oh, well, we don't need to treat the cholesterol. No. At 180, you, an individual with your genetic makeup, has developed these blockages. So we know that that number needs to be lower, okay? And we know that the best we have today, whether you like them or not, I take one, are the statin, the cholesterol-lowering drugs, unless you can be on one of these new injections, which are phenomenal, and we'll talk about that another time. But the statin drugs reduce your chances. If you started at 180 and you have a blockage, they reduce your chances of having a heart attack by 45%, which is a big number. Okay, why don't we go ahead? So here's a question amongst women having heart attacks. How many of them actually knew their cholesterols? Very few. 76% of women don't know. Now, why do we keep focusing on the HDL? The HDL we want high. That's the protective cholesterol. The higher it is, from an epidemiologic standpoint, the lower likelihood you're going to have a heart attack, heart disease. We used to talk about them as being little scavenging particles that scavenge cholesterol from the blood vessel walls and take them back to the liver to be dumped, so they can't get into your blood vessels. And the LDL is the paint that covers our blood vessels. That's what actually makes for the cholesterol blockage. Okay, go forward. So interestingly, about 6 weeks ago, 43 million Americans became hypertensive. The new hypertension guidelines came out, reducing hypertension definition from 140 over 90 to 130 over 80. So we now define 40 million new people as having high blood pressure. That's not that important. What I find vexing about this, and I don't really have an answer for you, okay, is that the blood pressure I see on you in my office, okay, is really not your blood pressure. Okay, your blood pressure is an average of all your blood pressures during the day. And the worst thing I can do for you, because you know what? You may or may not have heart disease, but the last thing you want to have happen when you go to see your doctor is he makes you feel worse than you did when you went to see him, okay? And if you know, God forbid you were waiting for me in the office, or you got a phone call that upset you, and your blood pressure is 165, all right, at the office, and I say, I want you to take these 2 pills. Take these 2 pills, because 165, with your condition, you need to take these 2 pills. And you say, but doc, my blood pressure is normally 110 over 70. And I say, I know, but you get to 165, who knows what's going to happen. Take these 2 pills. And you take them, and you go home, and your blood pressure is 80, and you feel like a wet dish rag, or you fall on the floor. All right, so that's my concern, my biggest liability. So the right thing to do, particularly if you ever get in a scenario like this, is to get your own home blood pressure monitoring machine, and take your own home blood pressure, because our blood pressure, and I joke with people, I tell them there's only one time in your life when your blood pressure is always the same. Okay? All right. Anyway, it's always varying, and if it doesn't vary, you got another problem. So anyway, go forward. Activity, physical activity. It turns out, and there have been some interesting studies showing that even in the absence of any medication, people with angina, all right, which is pre-heart attack chest pain, people who engage in vigorous exercise have a 30 to 35% lower likelihood of ever having a heart attack. It corrects your cholesterol profile, it keeps your blood vessels supple. Also, the neurologist will tell you the same thing. The one thing, it's not Sudoku, it's not crossword puzzles, but the one thing you can do to forestall the development of dementia is exercise. It's clearly the very best thing you can do for your health and to keep yourself young. Keep going. What does weight do? So it turns out that many heavy people don't have heart attacks, but they do develop diabetes. All right, and diabetes is an epidemic in this country that is rampant. About 1/3 of the American adult population is far overweight and developing prediabetes. And it, with all of its incumbent problems, leads to the development of stiffened blood vessels and atherosclerotic heart disease. Go forward. Okay, so this is just a little bit more about the complications of diabetes and how our bodies handle this. It turns out that if you can, if you have diabetes, and if you can convince your doctor not to give you insulin, there are many new medications that are anti-insulins that work to mitigate the amount of, but insulin itself is what we call a trophic hormone, that it thickens blood vessel walls. All right, you need to keep your blood sugar down, because if you don't, it causes renal disease and visual problems. But 7.5 million women over 20 have been diagnosed with type 2 diabetes, and 2.3 million go undiagnosed. And then 25 million Americans are pre-diabetic. It's a real issue. Go forward. So, smoking, I don't even need to go into this with you guys. I'm sure you all appreciate the detrimental effects. It's like walking around a house with a hammer and slamming the walls, and then cholesterol attempts to repair those walls by laying down at the site where the blood vessel was injured. The woman, I don't know if you appreciated this, but the angiogram, the catheterization angiogram that I showed you earlier, there was not a single blood vessel in her heart that looked like a piece of PVC piping. Every one of her blood vessels was caked with cholesterol. And I'll show you an intravascular, meaning driving down the blood vessel, ultrasound in a few minutes, that shows you caking of cholesterol here and there and everywhere in this person's blood vessels. Your blood vessels are supposed to look like PVC piping, okay? And smoking damages them. And then the body lays down cholesterol to repair, in the process of repairing them. Go forward. Okay. Can you keep your weight under control, physical activity, control your blood pressure and sugar? Okay. Why don't we go to the next one? Oh, sorry.
Let me get a picture of that. Okay. I
Good.
don't see it that well.
That's okay.
So I do it.
We'll mag it up.
And say,
So the next one is the small, I think it said kit something.
Oh, so I'm getting at it.
How are we doing with time?
Ooh, why did it turn off again?
Okay, tell you what. Oh, okay. I was going to say, why don't we go to the other one? So what we're going to see in the next picture is a person who's ruptured a plaque in a blood vessel, and we don't see the usual appearance of an egg timer. That is, you know, you have an egg timer that's symmetrically narrowed and then comes out, and that narrowing is analogous to that of the neck of the wine bottle that I was referring to, and that is stable cholesterol in the blood vessel wall. What you're going to see on the catheterization, on the angiogram of the patient who we'll show you, is a long, stringy clot. And it is in the blood vessel, adherent to the site where the plaque fractured, or the callus fractured, and because of the bloodstream, it's sailing off downstream. And when we see that in the heart cath lab, we actually have a vacuum that we can go in over a wire with and retrieve it and suck it out. And then we deal with the symmetrical narrowing by placing a stent. So women have the same problem as men, and unfortunately, if you look at the size of blood vessels, that women, being smaller individuals, have smaller blood vessels. But one of the other added benefits of exercise, let's talk a little bit about what exercise does. So exercise actually improves the size of our vessels. People who are vigorous exercisers tend to have larger vessels. Exercise changes your cholesterol profile so that your HDL rises, which serves to clean your blood vessels. The higher your HDL, the more return of cholesterol to the liver we see. Exercise improves your peripheral muscles, your conditioning, so that the amount of oxygen that your heart needs to pump to those blood vessels is diminished. Okay, because imagine if you're way out of shape, and we see this all the time. If we take a deconditioned person and put them on the treadmill, we find that within a very short period of time, their heart rate is at 100% maximum predicted for age. And the more fit you are, the longer it takes you to reach your maximum, your heart rate goal. And that's a sign of your musculature needing less oxygen as it becomes conditioned. I wrote a paper when I was young at Teachers College at Columbia. and we took, this is actually kind of a cool story. So we took 50 middle-aged women, and we asked them how they felt about their relationships in their lives, work relationships, home relationships, their love life, all this personal psychological stuff. And we started with these 50 middle-aged overweight women and told them that we would enroll them in a program and we would improve their outlook on life. So we began exercising. And we began to exercise them on a very strict protocol, not dissimilar from what you all do in cardiac rehab. And we measured their oxygen consumption. You know, when you're really fit, you're able to burn oxygen all the way up until you reach 80% of the maximum predicted heart rate for age. Okay? In individuals, and we've all done this, when you're deconditioned and unable to exercise and stay on your aerobic pathway, you reach anaerobic respiration. Your brain says go, 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 but your muscles say no, 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 no. And you begin to burn fat, all right? And as such, you accumulate lactic acid. And the reason we wake up in the morning after we've exercised too much, all right, with Charlie horse, is that you have lactic acid in your muscle beds. And that hurts, okay? But that also tells you reached your aerobic threshold. So when you want to, we can more or less skip the second one. No. Is this the second one, Kit?
Yeah, this is good.
Okay. Okay. So we can reach, so we took these women and we exercised them and we gave them psychological profiles along the way. And at the end, there were 50 to begin with. We were left with 40. And the editor of this publication said, we can't publish this. This is crap. 20% of people didn't finish the program. Did they commit suicide? I mean, what did you do to them with their exercise? And we thought, well, we know that they all improved. Amongst the ones who finished the program, they were all thrilled. They were enthusiastic. And we look how much we've improved their aerobic thresholds. They all felt so much better about themselves. So we went back and we changed the style the next semester. We enrolled 50 middle-aged women. And we said, would you like to feel better about yourself? And would you like to get in shape? And we're going to do it for you. But we need $50. So they each gave us $50 or $100, I don't remember. And they gave us $100. And every time they came for their exercise, we gave them back $5. And then we had 98% of the people complete the program. And I think that the take-home message here is that left on our own, you know, your treadmill becomes a clothing rack. So it's great that you all come out, and we appreciate it. And left on our own, we kind of forget sometimes. But it also improves your mental outlook on life, and you feel better about yourself, and you get out of bed with a little more, you know, zest in your step. So we want to help women 40 to 60 who are premenopausal begin to appreciate the fact that heart disease is a real relevant risk for them. Okay, and this is sponsored by the National Heart, Lung, Blood Institute and the National Institute of Health. Go forward. Okay, keep going. And so women have, probably because of estrogen and progesterone as they're cycling in their premenopausal years, they are cycling, and these plaques that are cased by a callus tend to rupture more readily. Okay, so heart disease is the #1 killer of American women. Heart disease kills more women than other forms of cancers combined. And once heart disease takes effect and permanently damages your heart, you can improve your musculature, but you can't make the heart better. The heart doesn't redevelop yet. We're working on stem cells and the like, but to date. So most women know that heart disease is their own greatest health risk. They do not know, rather, because we societally have learned that women don't get heart disease, and that's just not true. So it's sooner or later we need to accept that and be cognizant of it and the symptoms that go along with the development of heart disease. Come forward. There are many forms of heart disease, but coronary disease is what we're most commonly talking about, and that is here. There are arrhythmias. Women get more atrial fibrillation than men. All right, and atrial fibrillation is a heart rhythm disturbance, but it's not heart attack. It's another form of heart disease. You've all heard of that. So plaque develops, and plaque builds up in our blood vessels inside the inner layer, between the inner layer and the middle layer, and here's the outer layer. Okay, and that's where your plaque is. And what this doesn't show you is that we like to keep the diameter of the blood vessel or the channel the same. So in reality, a better picture would be to make this an oval, and the cholesterol starts out in the vessel wall, and then when it reaches about 40%, it begins to impinge on the channel, and that's where the tension occurs. When we give statin drugs, I like to tell people that cholesterol, that vulnerable plaque cholesterol, we put marbles in a brown paper bag, a lunch bag, and we keep stuffing the marbles in the bag, and eventually the bag ruptures, so the bag rips. Okay, and that's the bad day. That's when the cholesterol or the marbles are exposed to the stuff outside the bloodstream and a clot forms. So when we take these statin drugs, it's almost like chelation. People have heard of chelation. When you take it and you lower your cholesterol in your body, it's like taking marbles out of the bag. The likelihood of that bag rupturing is a lot less. When we do the repeat angiograms or the catheterization, we still see that their narrowings are there. They may regress about 5%, 7%, but the narrowings are still there. They don't actually go away completely. But we change the so-called vulnerable plaque, that is the bag stuffed with marbles, to a less vulnerable plaque, and we've taken marbles out of that bag. Okay, so that the bag is less likely to rupture. So these are the arteries. This is where the laces on the football would be, and this is the yellow plaque that's causing the flow restriction. And that's okay. You can live with that for a long, long time until something happens up here and a blood clot forms in the artery and it blocks the blood flow. Go forward. So you've all heard of procedures like bypass and angioplasty. Go forward. Heart disease can be prevented. And that's the take-home here, and it can be, the progression of the condition can be stopped. All right, I'm 60. So when I was younger, there were some people in this room, who came back every 3 months. What the hell's going on? Aren't our medicines working? I don't understand this. I mean, people came back, they had a heart attack, and then 6 months later they had angina, and then today, now, some of it has to do with our drug-eluting stents, and some of it has to do with bypass innovation. But today, it seems, and I think that this has more to do with the fact that we are able to lower cholesterol. Okay? Today, it's like we flip a switch on the disease. You have a problem, we intervene, there's an encounter, you get treated medically, and we seem to have learned to handle this disease. There are people who come back, but we don't see the repeat offenders the way we did many, many years ago. We've really, in my own lifetime, made substantial progress. And I think a lot of it has to do with blood thinners, antiplatelet drugs like Plavix and aspirin and so on and so forth, as well as the cholesterol-lowering medications. Estrogens are a little bit of a problem, although it's now turning out, you may have heard of hormone replacement therapy for postmenopausal women. It turns out it's probably not as bad as the Women in Heart Disease trial suggested years ago. And there may actually even be a protective effect because estrogen raises HDL. All right, in the first 6 months, there seems to be a slightly heightened risk. But afterwards, it's probably beneficial if you can get to that stage. And estrogen is probably not that as detrimental with respect to heart disease. There is a higher incidence of breast cancers and other cancers, but nevertheless. Anyway, let's go forward. So once again, same topics, high blood pressure, cholesterol, overweight, physical inactivity, development or treatment of the metabolic syndrome, which, by the way, is totally reversible. So I just want to spend 30 seconds on the metabolic syndrome, which is prediabetes. So once we get this, and this is an interesting concept. So men get a pot belly. Women get kind of the pear shape. They get the hips and the waist, but they don't have the typical protuberance in the front. But nevertheless, that fat that we've developed in the latter years is unique. It's different than the obese young fellow that you see, the very, very big 350, 400-pound guy, all right, who's obese overall. This is central adiposity or central fatness, okay, different in men than women. But that fat is hormonally active. It's very different than any other fat in our bodies. In fact, there are whole fields of medicine developing around that fat. And the fact that it makes a hormone called cytokine. And the cytokines are a group of hormones that gum up your insulin receptors in your body. Well, that's not a problem because we're healthy. So our pancreas just makes more insulin. So it's not like the insulin receptors don't work. They're kind of like grandma. You know, it's not that she didn't hear. It's just that you had to turn up the volume a little bit, okay? And if you bombard those insulin receptors with enough insulin in the early phase of the disease, they do work. But it's at the expense of very high endogenous insulin levels. Your body's making a lot of extra insulin, okay? Insulin working in the liver, okay, causes an enzyme to turn on that raises your triglycerides. As the triglycerides go up, and you may know this, as your triglycerides go up, your protective HDL cholesterol goes down. If you can, fasting, exercise, so on and so forth, lower those triglycerides, your HDL goes up, your risk of cardiovascular disease goes down. Additionally, as your triglycerides go up and your HDL goes down, remember in the 80s, we all wanted to take vitamin E because it was an antioxidant. And if we take antioxidants, we can prevent aging, right? We just all know we're looking for the Holy Grail. And if we take vitamin E, maybe it'll keep us young. All right, so it prevents oxidation. Oxidation is sort of the process of aging. Oxidation is why a piece of paper burns, why metal rusts, why your shoulders get stiff, why your hair turns gray. All right, turns out, you may or may not remember, well, vitamin E didn't work. But the concept of oxidation is real. And as your cholesterol becomes oxidized, all right, it becomes smaller and more dense and more what we call atherogenic, and that is more prone to get into blood vessel walls and cause blockage or plaque, okay? It's analogous to us, you and I have a cholesterol of 200. Now, I have 200 pennies. You have 8 quarters. When you measure the volume of cholesterol, it's the same. You're 200. But when we do particle analysis, we find out that I have many more particles than you, and they tend to be smaller and more dense, and they fit between the blood vessel wall cells, and they actually literally get in between the cells and cause plaque and inflammation and the development of atherosclerotic blockages. All right? You, on the other hand, may have large, dense, or large, fluffy cholesterol particles that float around through the circulation, can't bounce into the walls, but they can't get inside, and they eventually make their way back to the liver and get cleared. And that's why one of us gets heart disease and the other doesn't for the same cholesterol level. Well, there are medications that we can take that actually alter the size of your cholesterol particles. All right? And one of the treatments to alter that size is called exercise. All right? And exercise dramatically improves and lowers your triglycerides and improves your LDL particle size to take them from these small, dense particles to a larger, fluffy, less toxic cholesterol particle. Let's go forward. So again, family history is important. As we get older, everyone knows we're more prone to things happening, so that's not a surprise. All right. So we began to talk about this metabolic syndrome. So I want you to think of a bicycle wheel with an axle. That's the metabolic syndrome. And there are spokes that go out to high blood pressure, abnormal cholesterol lipid profiles, this obesity that we're developing, sleep apnea, atrial fibrillation, and all of the spokes on the wheel. And good news is for patients, we have a pill for this one, and a pill for this one, and a pill for this one, and a pill for that one, pill for this one, and a pill for that one. But who the hell wants to take that? Why not treat the one underlying problem, and that is get rid of the belly, the hips. Keep your weight down. Doesn't take a lot of change. You keep your weight down, your lipid metabolism improves. I like to tell people it's like walking into this room in February and the windows are open. And I say, what are you people doing? It's freezing in here. And someone says, I'll shut the windows. And I said, no, don't shut the windows. We'll just turn the thermostat up. Okay, so the insulin receptors are greasy, okay, and the furnace, the pancreas, is pouring out the heat, and the room eventually gets kind of toasty, and we say, we've solved the problem. The right thing to do is to fix the end product. Shut the windows. All right, clean up the insulin receptors, and then the pancreas gears down, and your pancreas lasts a lot longer as well. Go forward. All right, so this is just kind of interesting and scary. So 1 risk factor doubles your risk, 2 risk factors quadruple your risk, and 3 risk factors increase your risk more than tenfold. of having heart problems. So getting a handle on these risk factors that we talk about is so ever so important. Okay? Eating right, physical activity, not smoking, keeping your cholesterol low. Go forward. You can affect the difference by 82%. Okay. Go on. Why don't we go ahead to the last set of slides, which are some interesting pictures, because I know time is kind of becoming an issue, right? Yeah. Okay, can you gear back into that? Yeah, to the last set.
Oh, yeah, I'm doing it right now.
And it's really the beginning of the last set that's most interesting. So I'll ask you, if you have them, to hold questions, and we can wait until this is done, and then I'll answer some questions. This is a 37-year-old woman with diabetes and no other risk factors. She's a non-smoker. And she had been, it's similar to the story I told you. I didn't anticipate this other woman having her catheterization today, but it's a similar story. She'd been to the doctor kind of poo-pooed the situation, and eventually, because of her atypical symptoms, she went to the emergency room and was actually having a heart attack. So emergency catheterization gets done. And here in the blood vessel, as she went in, you going forward? Here in the blood vessel, in the anterior descending, remember the laces on the football would be here, is this oblong-shaped object with a ruptured plaque here, and this is all clot. So she went through her treatment, next, and here the clot has been extracted and this stent has been placed and the blood vessels restored, and the heart tissue downstream has been bruised but not permanently or irreparably injured. Go forward. So again, at every age, more women die of heart disease than breast cancer, stroke, lung cancer, endometrial cancer. Go forward. And cardiovascular trends have diminished over the years, but much more so for men than women. Go forward. So go on. So this is interesting. This is actually kind of cool, and we do this often. So here are the 3 onion skin layers. 1, 2, 3. And cholesterol accumulates inside here, and this is cholesterol. And this is what I would refer to as the vulnerable plaque. That's soft cholesterol. That's cheesy cholesterol. That's the stuff that wants to rupture. Okay? When cholesterol starts when we take these, all right, and we put these people on cholesterol-lowering drugs, this gelatinous gray begins to turn more white like this, because we've extracted the cholesterol from out of this plaque. And this is a plaque. This is the wire and the device that's actually sending sound waves out to sound this blood vessel. Go on. So this might have been the angiogram. This is the vessel on the back of the heart, all right? And the other vessels are here, okay? And here's a 70% or 50 to 70% narrowing. You never really know. You're looking at a two-dimensional view of a three-dimensional structure, which is why it's helpful to have that intravascular ultrasound, that other device that we were looking at, where you can actually look down and look at the entire vessel. Go ahead. Go forward. So again, this is sort of just a summary for women, of course. Birth control pills, smoking, and menopause are unique risk factors. The rest of them are risk factors that we all enjoy. Go forward. It's not a men's disease. It's common and prevalent in all of us. Go forward. So the problem is that women present later because they're stoic and they tend to handle things better than men. They don't whine as readily as we do, and therefore they don't get the attention that they need as quickly as men do. All right? And they also tend to have smaller blood vessels. Go forward. And you can see the dramatic rise in the incidence of coronary artery disease before and after menopause. Go forward. Go forward again. This is smoking added to. So the other issues, because a blood vessel that is choked off with cholesterol in the heart, all right, narrows. a blood vessel in a large blood vessel, when blood vessels accumulate cholesterol, there's slippage between the inner and middle layer of the blood vessel, and the blood vessel wall tends to dilate, and that's what aneurysms are. So 98% of abdominal aneurysms, which you've heard of, all right, are atherosclerotic. It's the same process that's going on, and the treatment for them is commonly the same. And as long as they're less than 5 centimeters, all right, we treat them conservatively. But to recognize that a small blood vessel accumulating cholesterol narrows, and a large blood vessel that accumulates cholesterol tends to dilate, and that's what an aneurysm is. Go forward. So typical angina, as you've heard of, and maybe some of you have experienced, is a strangling, suffocating sensation with a heaviness or a pressure. But women experience different symptoms: shortness of breath, funny upper chest pains, sharp pains, shortness of breath. And this is interesting, what you will learn again and again and again is that when women have heart disease, they complain of fatigue, profound fatigue. Much more so unexplained, much more so than any other symptom. Going forward. So what we do, these days, we like, for people who you suspect may need treatment for their atherosclerosis, I like this coronary CAT scan. Coronary calcium score is very helpful in people who've not been diagnosed as having the condition. Stress testing is of course helpful, but in women, women tend to have a little bit of a different metabolism in their hearts, and the treadmill stress test leads us to a falsely abnormal or a false positive treadmill stress test, all right, in about 30% of women, even though their condition is normal. The EKG portion, which is what we're interpreting, appears to be abnormal. So we typically have them do some sort of an imaging study along with the stress test, and that is much more diagnostic and accurate. The echocardiogram and the EKG may be perfectly normal. Remember, unless you've had a heart attack and done damage to the heart, what we really wanted to find are the people who are going to have a heart problem, rather than finding out about it post facto. And ultimately, in the long run, heart catheterization is the kind of the gold standard, but it is invasive going forward. So again, unusual fatigue in the weeks prior to a heart attack. 71% of women. Sleep disturbances, many other conditions, okay, that are somewhat indigestion shouldn't be overlooked, because again, the vagus nerve to the back of the heart is the same one that branches to the stomach. So intermittent indigestion, particularly exertional indigestion, is something that we need to be aware of, cognizant of. Okay? And shortness of breath is a function of the amount of heart muscle that's not functioning well. Weakness, fatigue, and the chest pain. Go on. Okay. So what's most important is getting blood flow back to the heart, okay? And time is very important. Going forward. There really is no difference in the biology of what goes on. It's in the recognition and the fact that we've kind of fooled ourselves into thinking that women are immune to this condition. Not true. Go on. Diet, very important, all right? Grains, legumes, low-fat diets, fish, all have protective effects. Go on. In New York City, they've outlawed trans fats. Trans fats have to do with the saturated fat content. And you will also notice that when you order a dish in a restaurant, they tell you the number of calories. Because if you eat those calories, even if they're healthy calories, and you don't burn them, if you eat in excess of your metabolic needs, you will store those calories as triglycerides. And we talked about the fact that as you gain weight, and even if it's good weight, you know, a lot of people like eating nuts because they've all heard that nuts are good for us. For every gram of fat, you get 9 calories, all right? For every gram of carbohydrate, you get 4 calories. So nuts and oils of any way, shape, or form, whether they're good or bad for you, all right, give you over twice as many calories as do carbohydrates, okay? And they should be complex carbohydrates like grains and not simple sugars, as you know. Okay. All right, why don't we hold it there since we may be having technical difficulties.
That valve thing go around, I wanted to take a picture of it.
Oh yeah, where is that valve thing?
Where's the stent thing? Anybody got it?
Right here.
Did everyone see it? Okay, any questions? Sir,
That's a TAVR.
Well, since I have it in me, I gotta.
what's that?
TAVR. They look the same way as the TAVR?
That's a SAVR,
Okay.
a surgical aortic valve replacement. They look quite similar. It's smaller. Yeah. We have another one made by Edwards that is not, the difference between this and the other standard is that this is self-expanding. Put in place, it expands to find the walls to which it affixes itself. The other one is a balloon expandable stent, and it doesn't stand as high, so it doesn't block the coronary arteries that come off above, and it is expanded after insertion so that the calcium, it has a little bit better seal for the very rocky annulus that may prevent this thing from actually filling in and swelling in place. Okay, thank you all. Keep doing your good work.
Can I just ask you a mini?
Oh, please.
Drug-eluting 2015.
Yep.
I had. Well, that's because I had the valve and Dr. Brown wanted everything done. Versus 2013, 2 of them, and 2011, 2 of them that weren't drug-eluting. Do those guys have to be replaced one day?
No.
Oh,
So
that's good.
if you don't re-narrow a stent, all right, and if you don't re-narrow a stent, all right, then it's good forever. And that is if the scar tissue develops, you will know about it with a bare metal stent, not the drug, but with a bare metal stent. If it's going to re-narrow, it re-narrows generally 99% of the time within 6 months.
Oh, in 6 months, so I'm a good munchkin.
If you made it, yeah, okay.